is Dr. Ross Crawford. He's from Australia. He's a robotic knee and a hip surgeon. For me, I'm Dr. Manoj Vadva. I'm heading Max Hospital, Mohali, and I'm the course director for this Elite Arthroplasty Congress. On my right is Dr. Jeffrey Jeller. He's from New York, USA, and Dr. Jeller is going to be performing the first robotic live surgery beaming from Max Mohali into this JW Marriott tomorrow morning. And the system we're going to be deploying tomorrow, the implant is also the launch for the first time in the country. It's called as the Journey to Uni. Uni means that you're not replacing the entire surface of the knee joint, you're only relining one particular part of that, one particular compartment of that.
So the ligament will be intact?
Ligaments and structures will be intact. So why don't you add up on this thing?
Sure. Partial knee replacement typically aims to replace only, in about 85-90% of people, the inner half of the knee, which is in the vast majority of people, that's the part of the knee that wears out first. So in the earlier stages of disease, what we hope is to catch it early, replace the inside half of the knee, and then really stop the arthritic process from progressing. But the benefits of a partial knee are a smaller surgery, a faster recovery, and maintaining more of the patient's own natural anatomy in order to get them back to a hopefully more normal feeling knee.
So how sooner or later the patient can get back after the surgery?
Well, it depends on the person. It depends really on how quickly somebody recovers, but generally in the United States, where I do this, many times I'm sending patients home the same day. They don't even stay in the hospital.
Going back home the same day.
Same day or one night.
Small cut.
Yes, yeah, minimally invasive.
So it's very precise actually. You have to, microscopically visualize the kind of defect or maybe the ailment it has.
It's between X-ray, physical exam is when, the art of a partial knee replacement is in whether or not the patient is an ideal person for the surgery. So if the arthritis is a little too advanced, then they're not a good candidate for it. But if you catch it at the right time, they can be.
This is an important point we're saying, that this partial knee is not for everybody. You have to choose the right patient. The right indication is very, very important. Not that people start thinking, I have skewed up, totally bowed up legs, and this is one choice for me.
So it needs a lot of homework from your side actually.
It's a little bit of homework, yes.
Yeah.
A lot of, because you have to, make the patient free on the same day. It makes a lot of, impact on you. It's like pressurize you a lot actually. Because like your complete study would always, fetch the good results.
Yeah, well, it really starts with the patient, and we know almost at the time they come to see us whether or not they're a good candidate for a partial knee replacement. Meaning if a lot more of the knee is worn out, if the arthritic process has progressed a little too far, then we know those patients, even if the surgery is done perfectly, those surgeries will not have a good result because they have arthritis in other parts of the knee.
So, what is the success ratio? I mean, you're saying that it may be like not 100% successful all the time.
For the right person, the right candidate, we're in the 98-99%. If they get well. If it's not the right
cases, like what do they do?
I'm sorry?
The 2% failures. So maybe not the failures actually, but the not complete healing.
Well, there may be scenarios of infection, fractures, or some continued pain in the knee.
So does it involve you only to do this kind of surgery, or is it required a lot of other practitioners?
No, it's typically me with a variety of assistants.
So you can explain on this particular system.
Maybe if you have a total knee to compare.
So so we'll need a total knee implant.
To bring a total knee to compare.
So how long will it take the surgery?
Approximately an hour.
Approximately.
Yeah.
So and the sutures, what kind of sutures do you do after the small cuts? Do they need some sutures also, Marceline sutures?
Yeah, usually it's similar sutures to a full knee replacement, but just fewer, smaller.
The smaller one. Do they get dissolved inside itself?
It depends on the surgeon preference. There's a variety of different ones. People close knees all differently.
But you remember, it's not microscopic. It's 6 to 8 centimeters. It's still a cut.
Visible.
Yeah, it's still visible, and it's still.
Sutures are always visible. So basically it's not a so small cut. But
So
it's
this
like
will explain what. So this is a conventional normal total knee, and that one is a partial knee.
So if we compare the two of them together,
This is the original implant,
these are real implants.
real implant. This is what is a total knee. This is what is we are talking of.
So you might imagine it's just this segment of the full knee replacement is all we're doing. So it's only essentially 1/3 of the knee.
Of course,
That's
there's
much
a lot of
lighter.
difference.
we leave it in place.
Yep.
That's the new knee.
That's the new.
Yeah, that's the new knee.
Yes, that's it. See the difference.
Would you like to add something to it?
My thoughts are very much the same. What we're doing is taking a smaller operation that we can now do more precisely, and the robotic technology, as it's evolving, is going to allow us to get it
Some
more and
it
more.
will be on the mobile itself that you're driving home and you're doing the surgery.
No, just about like a driverless car. This is the beginning of a revolution in healthcare, where robotic healthcare is going to start to.
So high-speed machines are replacing the slow machines, and then probably the surgeries are over.
Yeah, I think surgeons are pretty safe. There's a lot of cutting and
Exactly.
balancing.
You know
and-
where it's need to be done.
Yeah.
How it's gonna help, and the quantity actually.
Yeah.
The quantity of procedure, the quantity of cuts, the quantity of measurement.
Yeah, so that's going, and we're still planning it and deciding it. And like an architect designs a house, and then a builder might do it and use good equipment, good machines. We'll be the architects who'll design and we'll do a lot of it, but this will just make us better. And then if it makes good surgeons better and training surgeons better, then it's going to be good for patients.
Good for patients.
And that will save some of the upfront costs of the staff. If you can do less reoperations, patients get back to work quicker, and then they're a very, sometimes you have to spend money up front to save money. It's like building a new road that allows, it costs money up front, but it actually allows increased productivity. And so going home earlier, getting to work quicker, functioning better, being able to do a lot more, will have long-term economic benefits for somewhere like India.
Do we have all the tools in India? Do we have all the facilities which require to be screened, or is it like one totally lacks, or any other hospital doesn't have?
No one in India has actually bought one yet. It's really only been, these sorts of systems are really just starting to be rolled out around the world, and but I have no doubt within 6 or 12 months that India will. And technology is a very big driver for the Indian future, and I think it will be a big part of Indian orthopedics.
Indians are the best doctors that do
Because they're very good surgeons.
Today's even guest, so he's bound to say so.
They're very good surgeons, and if you look at the US, who runs all the IT? It's the Indians. Indians are fantastic at this sort of gear.
So what's your take on that, Geoffrey? We are on that actually. I mean, how this surgery, you're doing it for once, and would others follow this particular thing?
Yeah, I mean, it requires a lot of resources. It requires a lot of training and concentration. But yeah, I think that if a hospital and doctors take that step into securing the technology, it does. It allows them to do a lot more than they've perhaps done in the past.